Okay. So we start. Okay, we ready?
Ready.
Good afternoon, everybody. We would like to invite Professor Richard Marcus from Residual. He is our guest.
Enjoying it?
Enjoying, yeah. So he come here for 4 consecutive years. No?
Yep.
Okay.
So
his topic of talk today is unmeasurable residual disease. Richard,
Glass half
please.
full.
thank you. So to everybody on the line, hello, thank you. Some of you may have heard I gave a lecture this. Oh, I can't even spell malignancy. Sorry. Just noticed that. I gave a talk last week on the evolution of cell therapy and gene therapy. I was asked to add something else, and I thought I would do something new that we haven't talked about, but we depend on, which is just, the tools we use to identify how far we are and are we making progress in hematologic malignancy. This is looking at measurable residual disease. And so they are tools, but the tools allow us to look at the depth of response. We can look at, said surveillance, which is if we treat somebody, we want to watch and see how long they can remain disease-free. But there's a lot of the tools we use, and they're all mostly laboratory. One, in the case of leukemia, we can look at our bone marrow, and we can do bone marrow by our eyes. They just look at morphology. We can look at cytogenetic tools or fluorescent in situ hybridization. Cytogenetics looks at the dividing cells. The fish or the fluorescent in situ hybridization is looking at the background cells. So cells could be at rest. The cell cycle G0, they're not even replicating, but you actually can look for a mutation. We do a lot of work in flow cytometry, and classically, in B-cell malignancy, we use cell surface markers. All B cells will express immune globulin, but it turns out that in humans, there's 2 light chain types. It's kappa or lambda, and they're both it's like 55% kappa, 45% lambda. So it should be biclonal if you look at a normal population. But if you have a disease that you would need to monitor, you can look for a single expression of kappa or lambda. Now we're moving into new tools of what we call next generation sequencing, is identifying mutations that we can follow and correlate the mutations with disease. And again, in B-cell malignancies, we're looking at immune globulin gene rearrangements because we know that it's clonal, and if it's clonal, it should have a unique immune globulin expressed. We learned years ago, going back to, I think, Tsunobu Tanegawa helped get the Nobel Prize for VDJC rearrangements. We know that there's the organization of immune globulin is to have a specific gene rearrangement between multiple areas, so it makes a unique structure that's on the surface of all B cells. So B cell 1 and B cell 2 have different immune globulins on their surface. What we're going to look for is a clone is going to be a unique, reproducible. And how can you look for them? You can look for them in the old days, we would take enough tumor, or we would identify enough bone marrow and specifically do a very not sensitive, we call it southern blot analysis. And a lot of times I've used that in the past. Like if someone has a disease and 15 years later, all of a sudden we see disease. And what we could do is quickly take a piece of bone marrow, or if we had material for gene rearrangement, we could say 15 years later, does the pattern look identical to what it did 15 years ago? If it did, we say it's recurrence. If it didn't, we say, oh, it's a new disease. It's second primary. Now, mostly southern blot analysis has gone away now because we have now a assay that can actually go across the variable region to say, is it a very, very unique sequence? And that unique sequence defines that B cell. And I'll talk finally at the end about the newest world, which is circulating tumor DNA, which people have talked about it for a while, the blood biopsy, but it looks like it's coming to fruition. Now, just to tell you, I threw this talk together over the weekend, but it's a summary of some talks I've given you, I've given before. Some of the slides in the first section were shared with me by one of my other joint doctors who presented a talk at ASCO, but the rest of it is stuff that I've put together for showing. And so what is measurable residual disease? For a long time, we used to say it minimal residual disease. Oh, I don't see it. I don't see it anymore. Well, it turns out that minimal is probably the wrong word, because many of the times our tools do not let us look deep enough to see what's there. So the tool itself will define the sensitivity. So if I look under a microscope and say, I don't see any blasts, and for acute leukemia, well, under 5% is considered remission. Well, that's, if it's under 5%, if there's anything there, it's minimal. Well, no, it's my ability to measure it by my eyeballs is less than 5%, but I have molecular tools that can go even deeper. And so we know that we're going to use the model of acute lymphoblastic leukemia. When we see patients who have a morphologic remission after treatment, expectantly, we know that only 60 to 70% of people are cured. And so the vast majority are going to relapse, but I can't see it. So there must be disease that's left behind. And so what we're going to do is look for ways in which we can deepen the response and to identify residual disease that we could decide to intervene. And what we're doing specifically are looking for disease burdens below the level of detection of light microscopy. How do we look for them? As I said in that first slide, if we're really looking for deep sequencing now, again, looking under the microscope, I can pick up 1 in 20, 5% or 1 in 20. Using cytogenetics, I can maybe get 1 in 200. Well, now with flow cytometry, and they call it multiparametric flow cytometry, you could do several molecules at the same time that's on the cell surface to say, I'm going to use this and use it to identify the phenotype of the blast when they had their active disease, and that unique phenotype can be re-examined in the future. And that is not standard. The problem is flow cytometry can be really tremendous with really good, tremendous flow cytometric analysis people. But institution to institution to institution, when you ask to get reproducible flow cytometry, it doesn't usually happen. And there you can get a sensitivity of like 1 in 10,000. Now we talk about next generation sequencing, which is taking and looking for a mutation that you can do basically look by deep sequencing, and you can get a sensitivity of 1 in 10 to the 6. The problem is it's got a very slow turnaround time. The turnaround time may take up to 2 weeks. When we send off next-gen sequencing, it may take 2 weeks before we get an answer. It doesn't really help you in real time. I will say there's a new company now that has promised that they will turn around next-generation sequencing in 5 days. So for most of our acute leukemia patients that are on research studies, we will do what we can to bridge them for 5 days while we wait for foundation medicine to get a turnaround. And then now we have quantitative PCR. We heard, for those of you in the room earlier, we heard a case about BCR-able tracking. This is there's a couple other genes you can follow by PCR, WT1, FLT3. The problem, again, is it is a tremendous test that looks for deep sequencing, and you can identify it. But what is the sensitivity? Most laboratories are 10 to the minus 5. There are some labs that'll be can get down to 10 to the minus 6, 1 in a million, and some very deep sequencing can be 1 in 10 million, 1 in 10 to the minus 7. So when you look at, when you try to compare an assay, one lab to the other, the most important question you say is, if they tell you it's negative or if it's not detectable, what was their sensitivity? Because the next laboratory will say, oh, we have a positive. So again, the pros and cons of these are based on of how we choose them, that, multi-parameter flow will give us, you got to know the immune phenotype when you start. Once you know it, you can then look for it in your follow-up material. It's got a very fast turnaround time, again, not standardized. Next generation sequencing, far more sensitive. It is FDA approved now for limited number of genes that are actionable. So we have a next generation sequencing panel that looks at 200 different genes. As far as the insurance companies are, you can only bill for the ones that are actionable. So a lot of them is just collected. And then quantitative PCR is pretty much the principal way we follow Philadelphia positive ALL or Philadelphia positive CML. When do you do them? Well, a lot of times, if you've already treated somebody, this is, you want to know you have to have a baseline. So you get your baseline at the time of diagnosis. But then you could say, when am I looking? I can do it after induction. 1 month afterward, did I get into remission? If I got to remission, how deep a remission? Well, I'm not satisfied. I'm going to give a consolidation therapy. I can repeat it then. You could say, well, I think I'm going to go put someone on maintenance. You want to get your baseline before you declare maintenance. And the question is, if you do find somebody on maintenance and you're MRD negative, how long before you call them cured? In the case of transplant, we use MRD frequent testing. We use it prior. We use it typically as early as 1 month, but typically 3 months after. And again, when is somebody cured? Are they cured at 1 year, 2 years, 5 years? How long do you follow? Interestingly, when you look at flow cytometry, a lot of times for bone marrow, you got to do a bone marrow sample. One of the questions in the case of next-generation sequencing, especially this is the assay called clone-seq, when they're looking for the hypermutation, the hypersomatic region, in the variable region, there's areas of hypersomatic mutation, and you can actually get the unique variable region. And it turns out that once you establish that the blood and the bone marrow are pretty equivalent, because the bone marrow is part of the vascular space. A lot of people forget that when your blood goes to the bone marrow, your blood marrow comes out. And so for many of these assays, we can actually show that you could just sample the blood longitudinally, and then be able to say, I can monitor the disease response. We do it for ALL, for the clone-seq. I'll do it for, myelofibrosis, for JAK2. If I want to get a depth of response, you can follow the bloods. That's a simple piece to give you an opportunity. How sensitive should it be? This was a study of ALL, acute lymphoblastic leukemia, and it came out of COG as a Children's Oncology Group, and it was retrospective. What the big question, and still remains the question, is what's the best test? And they were looking for comparing flow cytometry to molecular, to molecular, and they identified patients, a cohort of patients that were negative in both assays. And if you're negative in both assays, your event-free survival is going to be greater than 90%, but the disease is not going to come back. But if it turns out, if you're MRD positive in both assays, your event-free survival is going to be much worse, even though you've completed your 2 years or 18 months or 2 years of therapy. It does turn out that if you look at if you're positive in one or the other, it does seem that if you're positive on next-gen sequencing with the clone-seq assay, that may be more predictive than flow cytometry when you actually follow patients, because patients who were next-gen sequencing positive and flow cytometry negative still had a high relapse rate. So this is the issue in ALL. We look at ALL, and I think ALL led the way. It's just why we talk about it first is because MRD was proven in ALL to be predictive of outcomes, MRD positive status. And what this shows is that, you can't really see the pointer here, is that You looked at what the picture shows on the right-hand side. These are event-free survival. This was a collection of 20 studies, over 11,000 patients. When at the end of treatment, were they MRD positive, MRD negative, and you could see basically the number of patients that if you still had some detectable signal, it may be very low, but it was very predictive of relapse. So you really want to get to that non-measurable MRD residual status. And what we now also know is it doesn't matter what type of ALL you have. If you're MRD positive at the end of a treatment, it's very likely you're going to fail. So those are patients that you don't stop your treatment. And we use, after induction, after whole courses, and they're in maintenance, if we see MRD positive, we'll often reinduce them with treatment. What do we know from transplant? We know that ultra-sensitive next-generation sequencing shows that this is pre-transplant. Is if you're, like let's say you're 0.5% blasts, well, you probably got a, very high is like 1 in 1,000, greater than 1 in 1,000 cells. Your likelihood of relapse after transplant is 50 or 60%, as opposed to if you have, less than 10 to the minus 4, your hazard ratio still could be 3.56, but ultra, which gets you down to the 10 to the minus 6 level, I believe is the Hubble. That patient had the greatest likelihood of no relapse. And so this sort of looks at, again, this was a model from Jess Leonard actually created this slide. This is from a talk that she gave 2 years ago. This is looking at that clonotype. This is the clone-seq assay adaptive, technologies offer. And you can see if it's after transplant, if you ever have evidence of the sequence seen, 26 of 29 patients relapsed. If you're at the bottom, shows if you've never had clonal detection, no detect evidence disease, almost none of those patients relapsed. Actually, none of them did relapse. Sorry, there were some patients who died in remission, but there were some patients who basically had it occasionally. You could see a clone-seq positive. There's still a good likelihood that they'll be cured, but they still have a 5% chance of relapse. So there's all these measures. Are you ever positive? Are you occasionally positive? Or are you never positive? If you're never positive with a next generation sequence in ALL, you're probably going to do well. And this shows again now we're getting into CAR T. So what happens with these are slides from brexucabtagene autoleucel, also known as Tecartus, of patients who went to CAR T therapy. These are adult patients who were, they asked, what's the likelihood of actually achieving the MRD negative state? It turned out it was basically, if you're a child or a young adult getting MRD negative status, you had a greater likelihood of getting MRD negative status. It didn't matter if you're pH-like or pH positive. It didn't matter if you had prior blinatumomab or what your disease burden was before you collected. CAR T seems to work better in young adults than older adults. And so this led to this is all retrospective. This was presented at ASCO, because what we know from tisagenlecleucel in the young patients are that it can have a very deep response and a deep remission, often MRD negative, to the point that a lot of centers will not transplant a patient, afterward and say, we're going to follow them. As long as they're MRD negative, we trust that the CAR T is still controlling their disease. Well, they asked the question with brexucabtagene, what should you do? And what they looked at with brexucabtagene is, which is adult.
You're doubling up.
Which is adult ALL, that if you're MRD negative after CAR T, you have a chance of having a prolonged duration of remission. If, on the other hand, you were found to be clone-seq positive, of your original disease, you could see there's a very high risk of relapse. And what they ended up, that same group said, what are we going to do with, what should we do with adults? What should we do with adults? And they basically said, if we have somebody who got CAR T and they ultimately got something else, if they got consolidated with transplant, or if they were pH positive, we put them on TKI maintenance or even pump maintenance for chemo, they did better outcome than if you did nothing. So we know that CAR T in the adult is not satisfactory. And most of the time, at least in ALL, currently for our adult patients, we're taking those patients to transplant. I don't know, Dr. Nemechek, you want to make any comment on what you do any kids?
So in leukemia for kids, we still only have one commercial product available. Up front, there was a question asked the Children's Oncology Group of what to do with people that are positive MRD at the end of consolidation. That's by flow cytometry, not NGS. And that study randomized people to either get CAR T or collect CAR T or not. And I don't know the results of that study yet. It was kind of hard to enroll into because a lot of people crossed lanes and did whatever they wanted. But we don't know yet. And then in the middle of all of that, all the news about blinatumomab came out. So I honestly don't know what we're going to do with it right now. Like right now, it is dealer's choice.
So right now, I'd say with adults,
Yeah.
we will take them to CAR T. If they're next-gen sequencing negative, we'll feel comfortable about taking them to CAR T. I mean, take them to transplant. But if they're MRD positive after CAR, we'll often go ahead and give Blina or something afterward.
So right now, no child is going to transplant at end of consolidation positive MRD unless they have a minor sibling.
Okay.
So we are actually waiting second, third, which is why I'm receiving the patients I'm receiving for transplant with a lot of treatment.
Well, in this same presentation of adults getting CAR T for either relapse refractory ALL or persistent evidence, if you ask them what's the likelihood of being alive, well, you can see that if you're, these are all patients. If you're MRD negative, your 6-month overall survival is 94%. If you're MRD positive, you can be 100% alive. You know, there's still 100%. So you can rescue the people. But if you didn't have could never have a response, almost all those patients die quickly. That's ALL. So takeaway points, this is quick. MRD is part of standard of care. The MRD assay, whether you use flow cytometry or next-gen sequencing, you need a sensitivity of at least 1 in 10,000, with those evidence showing that is predictive of outcome. And you use that to guide your decision-making. What we don't know is when's the right time to be testing and how long you need to be testing. And ultimately, you need ongoing study. And in ALL, these are questions that were raised is, what if you have isolated extramedullary disease? You know, like if you had, CSF disease, CNS disease, how do you effective is MRD monitoring in that setting? Question I don't know. Extra, like if you have a mediastinal mass, don't know. And also importantly, what if your clone can't be tracked, with your next-gen sequencing? Then you depend on flow cytometry and, or until we trust our tools for next-gen sequencing of T-cell receptor, which we're not there yet. So moving on then to myeloid malignancies. So we know that if we do an allogeneic transplant for myeloid malignancy, that the relapse rates after transplant range from 30 to 50%. We expect a high relatively rate of relapse. We know if you transplant someone with active disease, good chance they're going to relapse. We talked earlier about relapse refractory AML. What do you do with it? Well, you can take those patients directly to transplant, and about 15% of them probably will have a chance of being cured, but 85% will come back. So you want to get the disease burden down before going forth. And so we know that your outcome of allogeneic transplant is influenced by your subtype of AML, your remission status, what type of mutations, what graft source you used. Did you use cord blood? Did you use peripheral blood stem cell? You use bone marrow? And of course, the intensity of your conditioning regimen. And it is increasingly recognized that MRD in myeloid malignancy is important to define risk of relapse. And we just talked about the ALL experience. And the AML, it turned out that very little was known, and I'll show you a proposal we took nationally back in 2016. And it was a good proposal. We were recognized as having a good proposal. But in our country, it was said, you know, we know that MRD analysis is good for ALL. We're not ready for it in AML. We don't know enough. And at the time it was turned down, now it's become, you know, this is what should happen. And so, but I will say, there's been two big studies, one from Roland Walters at the Fred Hutchinson, and the other at Betul Iran at MD Anderson, which showed that in AML, by flow cytometry, and they do really, really deep, you know, multi-parameter flow cytometric analysis, that if you're MRD positive before transplant, there's a 60 to 70% risk of relapse. And so again, AML may be important. There was a meta-analysis of MRD that was looked at in, this is now 2017. They went through 19 different articles over almost 1,500 patients to looking at whatever the tool was. And again, 20 years ago, we did not have really good MRD, you know, measurements in AML, but it was showed that if you were positive, whether it was flow cytometry, whether it was cytogenetics or FISH, that your hazard ratio of progression, you had a basically 2.76 means you're 176% more likely to relapse than someone who wasn't. The likelihood of non-relapse mortality was the same. So you weren't more likely to get toxicity, but your cumulative incidence of relapse had a hazard ratio of 3.65. And they pointed out that at the time, this original study, which again, they weren't deep sensitivity, the impact was independent of which assay used, how old the patient was, or what your conditioning was, whether it was a TBI-based intensive regimen or a reduced intensity. MRD was predictive. And so this is a study that was asking the question, what mutations should we be looking for? And this is one of the first examinations of patients who went to allogeneic transplant for myelodysplasia. And they said, you know, what happens with these mutations? And they identified in this panel of about 100 patients, what were the most common pre-transplant mutations that were seen in the MDS patient. Remember, MDS is a stem cell disease, so that it's really hard to eradicate the mutations because it's not a committed progenitor. So usually what you have is before transplant is your evidence of your disease. And you can say ASXL1, we now know is a high risk for failure. TP53, high risk for failure, very common in MDS. DNMT3A, TET2, intermediate. But these are sort of the scan of some of the mutations that we follow routinely for myeloid malignancy. Interesting, WT1, a lot of work on WT1, because you could follow that by PCR. They only had four cases. Now, what did you...
With the TP53,
what's that?
you go ahead first with those with the TP53. You go ahead first with hypomethylating agent.
Oh, yes, I do. Or now with venetoclax. But this is 2014. This is before venetoclax.
Okay.
So this is a long time ago. I'm just saying, but this is what the mutation, this is showing us the scope of mutations. And this is looking at pre-transplant. And they looked at the type of survival prediction. And what they pointed out was, again, in yellow is, in the very top slide, this is overall survival. The top one is if you had a karyotype that was complex versus a single mutation, a single chromosomal abnormality, you did better if you weren't complex. If you had not complex or you had unmutated P53, you did okay. But it turns out if you have complex cytogenetics and TP53, you could see it was almost 100% dead by within 1 year. This is the group that people have now, this paper is the paper that people use to say, why waste your time transplanting patients if they have P53 complex cytogenetic myelodysplasia? Because they're very likely not to have any benefit. And so, but on the other hand, if they have DNMT3 mutated or TET2 mutated, there was really no negative impact. So again, this tells us something important, that the mutations that we can see don't necessarily, they're not all equal. Some are much more predictive of failure and some are not. So this is all pre-transplant. Well, one of the questions that came up, and Batul Iran also, this was a presentation from a proposal that they did at the Tandem, they showed a Tandem. What about post? This is flow cytometry, and they're looking 30 days after transplant. And so that's the important part. What is your MRD status 30 days after transplant? If you're positive, you're group 1. If you're negative, they then stratified people by your ELN diagnosis, in age. So you have group 1, group 2, group 3. Group 2 are older patients with MRD positive or adverse cytogenetics. Group 3 are your favorable. But this is day 30 afterward. And it turns out, absolutely, if you look at this, your group 1, which is positive at day 30, 80% predictive of relapse. Group 2 and group 3, lower. And similarly, on the likelihood of surviving is if you were MRD positive at day 30, you're at 1 year, only 25% were alive. So post-transplant may be important. What can we do about it when we know it? Well, how do we prevent the relapse? Well, what they're saying is, if we have a good tool and a good test, we could actually intervene post based on preemptive treatment. Like if we see something that we knew ahead of time and it starts to show up, let's preemptively intervene. And so this was a study that was done looking at with preemptive donor leukocytes following WT1 as a mutation. And what they showed is, again, if you were MRD positive, this is a children's study with AML and ALL mixed. If you're MRD positive and you didn't get DLI, you did badly. If you're MRD positive and you got DLI, you did better. Or if you're MRD negative, you did well. And we were talking that issue about donor leukocyte. This is one of the strengths that this study particularly says, that donor leukocytes can really be effective, but it's most effective in the MRD positive state. So we at OHSU looked at our own next generation sequencing panel, which now, like I said, has over 300 mutations. Interestingly, this was the first examination, about 40 cases. They found, what we know in cytogenetics, if you look at all MDS, only about 35 to 50% of patients will have a cytogenetic abnormality. A lot of MDS is basically normal cytogenetics. At least at OHSU in our examination, this is an early panel, we found one mutation in 75%. Now it's over 85% of all MDS will have a mutation. And these are the mutations. Now, interesting, if you know about cancer, we think of lung cancer, we think of melanoma. They often have 25 to 30 mutations per disease because they take time to develop. Leukemia, when it comes quick for a lot of people, and you don't have a lot of time to develop a lot of mutations. And so you can see this is looking at 175 patients with AML. The average number of mutations per AML patient is only about 2. So it's a lot different than the solid tumor where you often see very high level numbers of mutations. And we published our experience on our first look asking this question about pre-transplant MRD. Is it predictive of failure? Because we went back and did our allotransplants for AML, and we went back and then we resequenced people. This was before we did sequencing, and what we showed is MRD positive, just like we do expect, MRD positivity predicts failure. And in univariate analysis, we went through a univariate analysis of age, type of primary versus secondary to AML, ELN risk, number of mutations that we saw. And you could see the only thing that showed up in multivariate analysis as predictive of failure in our small series was MRD positive status. So just to finish AML, there was a recent study, there was a BMT-CTN 0901 asked the question of reduced intensity versus myeloablative transplant. And what they ended up showing was, this was in AML, they identified that in red is predictive mutations that are predictive of relapse. In blue are mutations that aren't predictive of relapse. And if you look on the right, it was myeloablative, on the left is reduced intensity. If you had a DNMT mutation and you got a myeloablative transplant, it doesn't really matter. You're not going to relapse. But if you have a DNMT3 mutation and you have a reduced intensity, you could probably break through. And so you could actually start to look at this, identify which mutations are predictive of failure, which mutations are not predictive of failure. And that actually, I'm going to skip this, but this just said that, this just shows you the time to failure. And what came out of this, as I said, we do a 200 panel study. So Chris Oregon is at the NIH, and he has a deep sequencing where they can do myeloid deep sequencing down to 10 to the 6th. He came up with a 10 gene signature. This is the 10 genes. That's all you need. You don't need 200. 10 genes will be all you need for AML prediction. And this has become the sort of the standard in our country. And just to mention on the last one on myeloid is, okay, we're FLT3 ITD positive. What do we know about FLT3 ITD? And, there's studies out there. We did one called the RADIUS study with midostaurin. The main one that's been used is SORMAIN study from Germany using sorafenib that said, if I put 3 patients to transplant and I put them on maintenance therapy, they're very likely to do well. Then in randomized trials compared to those that got placebo, had a much higher rate of failure. So there's a United States study, it's called BMT-CTN 1506. Mark Levis is the first author, which said, if I give people gilteritinib post-transplant for 2 years, should they do better? Well, what came out of the study was surprising, is that the study was negative. It was placebo versus gilteritinib. And when they went across the study, it was found to be no difference. But that was in the populations of placebo versus gilteritinib. But if you went to the population of MRD positive FLT3 prior to transplant or anytime post-transplant, those patients predicted they needed gilteritinib. So the patients who are MRD negative before transplant, which is often happening now because people get midostaurin plus induction therapy, you could transplant them, but they do not need maintenance therapy. It's just the ones that have MRD positive status. So I told you, we proposed this consortium study, which was to compare mutation, approaches, AML, MDS, next-gen sequencing flow cytometry. When we did this, people said they like it, but they did not believe that it was going to make a difference in AML. That was 2016. So just to finish, I think I have about 10 more minutes here. And so this is just reminding what I said at the very first slide. We have all these tools, but I'm also going to talk about a new tool which is coming, which is circulating tumor DNA. And I'm sure a lot of the clinicians know about it, but a lot of others, even to me, it's sort of a new assay. And so again, in lymphoma, now we're going to talk about large cell lymphoma, the third hematologic malignancy. And what we know is we give frontline therapy. The frontline therapy is R-CHOP or, R-POL is CBP, or CHIP, R-POL is CHIP. And then we go for 6 cycles. And at the end of 6 cycles, or whenever we do our end of treatment assessment, we expect a complete remission in 75% of patients. Deauville score 1, 2, or 3. But 15% are still going to relapse. So can we do surveillance for relapse? We also know that after frontline therapy, there's incomplete response in 25% of patients. Sometimes that PET scan, though, is just inflammatory tissue. It's not active disease. So we'll say, do a biopsy to see if it's active disease, or repeat the PET in 3 months or 6 months to see if it becomes PET negative. So either surveillance or go to salvage therapy. So this is a model. And I say, beware the Deauville 4, because if you have someone with, like your case you present this morning, or someone presented this morning, Deauville was, Deauville 20, SUV of 20, and then it goes down to a Deauville 5, a score of 5. Yeah, an SUV of 5, you say, well, that's a Deauville 4. And is that disease or is that just ongoing activity? And it was hard to know what to do with those patients. So we know, though, that we talked about the clone-seq assay, which is the next-gen sequencing assay used characteristically for ALL. And this is studied from David Miklos at Stanford, which saying that, if we use clone-seq, now we have a sensitivity in 1 in 10 to the 6th. It can get down to 1 in 10 to the 6th. That if you ask the question, these are after autologous transplant. They actually went back to the apheresis. They looked at the apheresis stem cell, the time of apheresis, or at 90 or 3 months after transplant. If you show positivity for your clone-seq positive at the time of collection, before auto transplant, or even after, the relapse risk was extremely high. That's the curves in blue, the MRD positive status. So we know that so our tools right now are flow cytometry and PCR. Well, now we have circulating tumor DNA. This is now a commercial assay that's available. And so I have to go through this slowly. So immune globulin sequencing, that's our clone-seq, 1 in 10,000 routinely. At the end of therapy, at the end of treatment, 25 to 30% of patients will give you a signal. There's a thing called CAP-seq, which is cancer personalized profiling by deep sequencing. And what they're doing is looking for whether the immune globulin itself, as well as specific mutations in that disease. And you can actually find one, but now the sensitivity goes to 2.5 in 100,000. But now we have phase Z-seq, which has an 80 to 90% sensitivity for detecting residual disease. It has very low background error. It's very personalized cancer sequencing therapy. And so there's a review, Ryszkowski, he's at the NIH. There's a review for anyone new. JAMA Oncology in January wrote this review on sequencing in lymphoma, and is an important paper that just came out in JCO last month, where he actually shows he will guide us. It's I guess in August, not last month, 2 months ago, which is now looking at the role of circulating tumor DNA. So if you look at CAP-seq versus phase Z-seq. So CAP-seq, you can get 1 mutation that you're tracking per genome. With phase Z, you're tracking 3 mutations or 4 mutations or 5 mutations from blood. It's circulating tumor DNA. And so you're actually tracking mutations. And what he did is go through 5 prospective trials that got the post samples to actually do the analysis. And this was comparing it to flow cytometry, to PET scan. And you can see at the end of treatment schedule, this is sort of hard to follow, but if you had no circulating tumor DNA detected, very high cure rate. If, on the other hand, you have circulating tumor DNA, that's the curve in the red, it is very predictive of relapse. And again, this is at the time of, 1 month after your last dose of R-CHOP. That's when it was collected. And these were samples, and then they matched it up to ask the question, and they have a measurement of what is level. And so circulating, you can see in the three squares, there's a sensitivity. If it's over 0.01%, that's high. If it's in between that, it's low. If you don't have it detected, it's not detected. And you could see the little curve, the round circle that says no progression, that the vast majority were, the sensitivity was over 90% that it was predictive. And if it was, you did see it, progression or death to 75% of the people.
The patients were in the clinical remission.
They were in clinical remission after R-CHOP. And these were he got the samples from 5 independent studies. And so he's actually so you have the clinical trials taking place, you know, the clinical course of the individuals, but then he basically went back and reanalyzed the sample. And so this was remission assessment by circulating tumor DNA. And you can look at, on the upper, it's PET sensitivity, you know, PET remission versus PET negative versus PET positive, versus on the right, circulating tumor DNA. And you can see, again, the circulating tumor DNA was far more sensitive. And if you were PET negative, you could still see some patients had what was in the red on the bottom right, you had circulating DNA detected in the PET negative patients. Most of those failed. And in the PET positive patients, circulating tumor DNA, when you saw it there also, it also was failed. So it's a complex picture, but it's all of a sudden, it's like maybe changing things. So I say the future is now, because they predicted then what we need to do if we're going to get phase ed into practice. What we should be doing on frontline therapy, incomplete response, tissue biopsy, surveillance. But if they have this 15% risk of, if we do this, if you have a Doble score, once you have your PET, do an MRD analysis. If you're negative, no surveillance. If you're positive, at the moment, we can't 100% tell you, but you probably need a clinical trial. Well, the clinical trial is opened. You asked about off-the-shelf product this morning. Well, Allogene has an off-the-shelf CD19 CAR, and they have a randomized open-label study. We're a member of that study. Is that they would prefer IPI 3 to 5 patients, because that's a higher likelihood of having positive circulating tumor DNA by the phase ed access. But it's going to be open-label evaluated. Should we be doing CAR T? Should we be doing CAR T then? Because that's what the study will be. Is if you go to the top and you're MRD positive, the clinical trial is a 2-to-1 randomization of either going immediately CAR T or observation. And if your observation in a year you relapse, you cross over to immediate CAR T. You'll get your CAR T. But the question is, you're using the deep sequencing to say, if I use CAR T to consolidate R-CHOP, if you need it, you're going to avoid a lot of long-term complications. And so the trial is open. We've already enrolled. We've signed up about 20-something patients. Not all have reached the end of treatment. We've had, I think, 7 patients go through end of treatment. Every one of them have been negative so far, but they haven't relapsed yet, so we'll see. But it's an interesting thing. And so I said, what do I do currently at OHSU for large cell patients at end of therapy? If I can, I'll do the Allogene study if they're willing, because I think that it's an interesting clinical trial. If they say I don't want to be on the trial, I'll use standard of care PET scans and follow the NCCN guidelines pretty much through the end of 1 year and don't do it after that. If I have an autologous transplant or CAR T, I'll do standard of care PET scans. We haven't used phase ed yet. We have a SWOG, a randomized trial for post-CAR. If you're stable or PR after CAR on day 30, you use the PET scan will just drive you to one of 4 arms. It could be observation, because some of those PRs will go on to CR over time. It could be immune conjugate versus bispecific or combination bispecific and immune conjugate. And so we are using clone-seq in selective situations. We have not yet, this is new data for us, we have not yet adopted the circulating tumor DNA. We now know how to order it for the phase Ed assay, but we expect that they will be moving this forth to monitor patients longitudinally. So that's my little quick put together this weekend on MRD between ALL, AML, and large cell lymphoma.
Thank you very much.
Thank you.
What is circulating tumor DNA? Do you need baseline before treatment?
For the circulating DNA,
Yes.
Yeah, you should. but that should be easy to get from the tumor.
Get up and dance for the night.
The leader, so.
And if I wasn't as, I put this together, so it's not as smooth as it could be, but I do, like I said, I've given,
I think I got it.
I think I want to do the, I want to do the.
Record. Yeah. I don't know how to do that.
How's the lunch?
So pretty. It was good. But now we're trying to stay awake.
Me too. Coffee.
No. If I drink coffee now, I won't sleep at all. Too late. I can't after 2 o'clock. I can't have coffee anymore.
Yeah.
Yeah.